Good afternoon. My name's Parv Sains. I'm a consultant general and colorectal surgeon, and I've been kindly invited by the BJS Academy to give the introductory talk for a series of medical legal webinars and podcasts to do with medical legal issues in surgical practice. The introductory talk that I'm about to give covers the basics and the framework of the medical legal aspects of surgical practice and the frameworks that we work in as surgeons. As a matter of introduction, as I say, I'm a consultant colorectal and general surgeon. I am also the medical legal lead for the Association of Surgeons of Great Britain and Ireland. I, as a background, studied medicine at the University of Birmingham. I hold a master's in medical law, which I was awarded from Northumbria University. I hold a doctorate in medicine from the University of London. I'm a fellow of the Royal College of Surgeons of Edinburgh. And as mentioned before, I'm the medical legal lead for the Association of Surgeons of Great Britain and Ireland. My qualifications in respect of delivering this talk, slightly repetitive, but as I have mentioned, I hold a master's in medical law, and I wrote a thesis entitled Institutional Factors and Exceptional Circumstances, Is Bolum Fit for the 21st Century? And I also hold a certificate in law, civil law and procedure from Cardiff University, which entitles me to independent expert witness work. So why give this talk? I think it's well known that medical legal frameworks are not formally taught as a topic during training, and medical legal issues in surgical practice, in medical practice in general, are poorly understood. It's often thought of as a very defensive kind of thing to study, to look at. And this can lead to lots of fears and misunderstandings about the medical legal world, especially given the fact there's been some high-profile negligence cases, and also in view of the high litigation costs that are incurred by the NHS. There's lots of stigma attached to sort of medical legal issues, and my personal thought is this is partly due to the lack of information, lack of understanding that the medical and surgical fraternity have with medical legal law and the understanding. We all know that regulatory investigations, for example, from the GMC are rising. And again, there have been some very high profile cases with various lenses on various cases. And again, this constitutes a very sort of anxiety-provoking situation for the surgeon or the clinician, where one tends to be quite defensive. So an understanding of the medical legal issues will hopefully lead to a sort of a more open approach to this subject. My final point on the slide here, I think, is the most important, and this really encompasses how an understanding of the medical legal frameworks may help in general. And this is it a tool for enhancing patient safety? So as surgeons, if we understand our medical legal frameworks, if we attempt to adhere to them, I mean, there are some questionable aspects. However, if we generally adhere to the medical legal frameworks that we work in, will this enhance patient safety? This is a word bubble which I think encompasses all that. I won't go through every single part of this word bubble, but I hope you can see that a lot of these words explain or highlight a variety of things that we think about when we look at patient safety and medical legal matters. My personal thoughts are that attention to the frameworks ultimately could improve patient safety as a whole. So the scope, this is just to reiterate, I'm not a lawyer, and I will not be discussing specific hospitals or surgical units. As far as case law goes, I will only be talking about the case law which is pertinent to the medical legal tests, and I have purposely done this to avoid a list of cases, which I'm sure at some point, if we develop the medical legal series, we can look at specific case law that would be pertinent to more focused areas of practice. So what I'm going to give you today is a general look at negligence and the tests of negligence. So negligence is part of the law of tort. There are three components, and there have to be three components that are in place for negligence to be proved. First of all, there needs to be an existence of a duty of care, and there then has to be a breach of that duty of care, and then there has to be causation. We will expand on this in a minute. The standard of care is essentially discussed later on in the talk, but just as an introduction, we'll be talking about BOLEM, which is the primary test of negligence, and BOLITHO, which came along later as some have termed a gloss to BOLEM, and we'll be talking about, or I'll be talking to you about the differences, indeed, if any, that this is made on the BOLEM test. Montgomery is to do with consent, and that is a separate subject. I think there will be a separate talk on this coming. So I have just mentioned this for now, but we'll not be expanding on this particular law. So civil claims and negligence. There is no automatic right to compensation if someone has suffered or has sustained an injury. So if a patient does have a mishap and there's a medical error, to succeed in a claim for damages, the patient has to prove three things effectively, or the claimant, as they become, have to prove that the defendant is in a breach of duty owed to them. So this would be there's been a drop in the standard of care. Secondly, the injury, damage, or loss has been caused to the claimant as a result of the breach of duty that was owed to the claimant. So this is the but for. But for an action or inaction or omission, the claimant suffered an injury or suffering. And also the extent and nature of the injury or the loss and damage caused has to be quantified. To look at Donahue, this is always a fun thing to start with because it has a bit of an ew factor. The duty of care was first put down in law by the case of Donahue versus Stevenson. On the 9th of April 1929, Mrs. Mary McAllister brought an action against David Stevenson, who ran an aerated water manufacturer factory in Paisley in Scotland. She claimed £500 damages for injuries sustained by her through drinking ginger beer, which had been manufactured by David Stevenson. The background of the case is that she essentially bought a bottle of ginger pop, duly drank it, and at the bottom of it there was a snail. And she claimed that the duty of care that David Stevenson had and the manufacturer had dropped, the standard of care had dropped, and therefore the duty of care had been breached. And this essentially coined the Donahue versus Stevenson case, which details the duty of care as a law. Now, I've mentioned standard of care previously. This is a very complex subject. One definition of the standard of care is the level or caution or diligence expected of an individual to prevent harm or damages to others, determined by the behavior of a reasonable person in a similar situation. In simplistic terms, it is what someone would do with care and attention that would be expected of someone doing a diligent act. The setting of the standard of care is a very complex thing, and it involves guidelines, it involves statute, it involves laws, and ultimately, in medical negligence, the arbiter of the standard of care should be the courts. Now, in order to be the arbiter of the standard of care, the courts will also obviously look at guidelines, but also expert witness testimony, sorry. And we will look at or talk about that a few slides down the line. So essentially, a breach of duty is a drop in the standard of care. The other concept I want to introduce is the balance of probabilities. And the balance of probabilities really describes a binary situation where you have a 49% or 51% divide. And the arbiters, in this case, again, it should be the courts or the judge, needs to decide on the balance of probabilities whether an act or omission has been negligent in terms of breach of duty and then also causation. So the standard of proof is simply the balance of probabilities. The inherent probability or improbability of an event remains a matter to be taken into account when weighing the probabilities and deciding whether on balance the event occurred. So common sense, not law, requires that in deciding this question, regard should be had to whatever extent appropriate to inherent probabilities. This sounds like a lot of gobbledygook, but in simple terms for the surgeon is that did an event happen, and on a binary term, was the act negligent, is where the judges will decide whether there has been negligence or not. I won't go word for word for Lord Hoffman's statement, as it essentially says exactly what I've just been through. We'll talk about Bolam. I've stated Bolam as being the first, essentially the initial test of negligence, and the case involved a claimant who was undergoing electroconvulsive therapy as treatment for his mental illness. Again, this was in Scotland, north of the border. The doctor did not give any relaxant drugs, and the claimant suffered a serious fracture. So there was a divided opinion amongst professionals as to whether relaxant drugs should be given. If relaxant drugs are given, there is a very small risk of death. If they're not given, there is a small risk of fractures. The claimant argued that the doctor was in breach of duty by not using the relaxant drug. It was found that the doctor was not in breach of duty, and McNair J, who was the judge, essentially, when it went through the House of Lords and the Bolam test was formulated, said, and I do stress that this was at the time, and it refers to a body of medical men, but obviously this now refers to a body called medical opinion. I will read it verbatim. A medical professional is not guilty of negligence if he has acted in accordance with a practice accepted as proper by a responsible body of medical men skilled in that particular art. Putting it the other way around, a man is not negligent if he has acting in accordance with such a practice merely because there is a body of opinion who would take a contrary view. In simple terms, if there has been a potential negligent act, or an act has been questioned, if one can find a body of opinion that would have acted in the same way, there is a potential defence. And we'll come on to the potential problems with that, which is the criticisms of Bolam. Bolam has been under attack since its formulation, and primarily this is because of the paternalistic perception of Bolam. So doctor knows best. So, you know, it's been a perception amongst the general community, amongst lawyers, that actually that this is all about self-governing, doctors making up their own rules. And I think some of these criticisms are probably true. But there's a very fine line between having expert or the judiciary getting expert advice from very experienced clinicians in a field that is very, very narrow in order to make a decision, and making their minds up without this expert evidence. We'll discuss this in a little while as well. So the criticism of Bolam basically being the liabilities determined by the medical expert evidence, the medical profession appear to set the standard of care. And the courts defer to medical opinion rather than impose judicial opinion. And the defendant may find a body of opinion that would have acted as they do to avoid negligence. So in simple terms, a doctor may go and find a bunch of friends who will say, well, yes, I would have done the same thing, and therefore it's a body of opinion that would make an argument, and therefore negligence may not be found. So along comes Bolitho, which unfortunately was based on a 2-year-old child who, again, this is a summary. The cases are very in-depth otherwise. So the summaries of a 2-year-old child admitted to hospital suffering from breathing difficulties. A senior pediatric registrar was summoned, but was unable to attend. The child unfortunately died. The one omission here, sorry, is the fact that before this, the child had been attended to by a medical team, and the question was as to whether the child should have been intubated or not, and whether this would have saved the child's life. The doctor essentially gave evidence that had she attended, she would not have intubated the patient, and the verdict was of no negligence. This was held. Now, the judge there essentially said that the defence could not be considered reasonable if the body of doctors or supporting witnesses were not capable of withstanding logical analysis. A case which is defended based on practice which is not reasonable or logical thus cannot be defended. So what Bolitho brought along was the concept of logical analysis. So, you know, what did Bolitho do, or should I more correctly say, what was it meant to do? It was meant to probably take away some of the paternalism and the Bolam's principle of you can get a group of people to come and defend you if they do the same thing, or they say they do the same thing, and introduce the concept of evidence-based. So it's the application of logic, it's the application of a formulated way of thinking, and also it provided an opportunity to challenge McNair's Bolam test, and also enable the court to reject expert evidence where there is no logical foundation. So it really was to try and probably get or jockey the position back to the judges being the arbiters, rather than rely solely and heavily on medical opinion. There are pitfalls in this, and there are pitfalls in Bolam. if you look at current case law and the way the tests of negligence are applied, and I'll refer to my particular thesis, it does seem as though Bolam still exists as the main test. So it still seems that there is some deference to the medical experts as regards the court making decisions on negligence. So the second part of the talk, I thought I'll quickly have a chat about the understanding of or how the law sees it, and the understanding of legal profession's approach to facts and evidence. I think it's important to look at this in order to improve clinicians' actions and reasoning, and ultimately also hopefully to improve patient safety. If you put yourself in a position where you are on the ward or you are in an operating theatre, if you are in an emergency situation, it is very important, and I think absolutely paramount, that you document what you've done absolutely accurately. And I'm sure, again, in the medical legal series, we may expand on this, but you have to be clear about what you put down in writing. Something that possibly happened or probably happened in the eyes of the law is a bit ambiguous. What could or would or should or what might have been said or may have been said, again, is ambiguous. So what I'd encourage you to do in terms of looking at it through the test of negligence, i.e. Bolam or Bolitho or both, that everything you do is documented very, very clearly. So, for example, Mrs. Smith, the patient was better, or Mrs. Smith's symptoms had improved. This is slightly ambiguous. The way to really make yourself clear is Mrs. Smith, the patient, was better because her pulse rate had dropped from X to Y, her blood pressure was, and it's giving the actual detailed criteria as to why Mrs. Smith was better, and then giving your reasoning as to, based on this, why a certain act was performed or omitted, and this will avoid ambiguity. So be mindful, even when, for example, writing operation notes, is to put your thoughts down as to why you did a particular thing, but put them down clearly and demonstrate your reasoning. One thing to remember is that lawyers do not have an implicit medical knowledge, or assume they don't have. I mean, there are some lawyers who are very well versed in medical matters and are very experienced and very erudite. However, always assume that they do not have. It's like explaining things to a 12-year-old or even younger. That's the way you should assume things. So again, I reiterate this because it's very important. Explain and document things in simple, concise, logical terms, and demonstrate a logical approach and reasoning process based on material facts. And you'll come across material facts in the legal world quite often, and also, very importantly, also document the weighing of alternatives. So had you considered alternative methods of management, treatment? Had you discussed the alternatives with the patient? And that's more part of consent. So just to slightly reiterate, when the legal teams look at these things, they want to have a look at reasoning. Did the doctor identify the facts and evidence where material to the issue, and were they addressed? And also a description of the reasoning process resulting in the action or inaction that was taken. Explain your decision making, show your reasoning, tell a story. And I think, when it comes to those tests being applied, Bolam or Bolitho or both, that will stand a clinician in good stead. Contemporaneous documentation, documentary evidence in clinical records carries weight in any subsequent investigation. I'm sure we've all been in a position where a set of notes have been handed to you, and either for a witness report or a coroner's report, or just for answering a complaint, and this the actual event may have occurred 2 years ago, 3 years ago. And you have to go back to your own notes, which is a case in point. For one, make the notes legible, and two, if you have made accurate notes, you will be able to compile a report, and it will carry weight if it has been done logically and you have put down your reasoning. So lawyers will look for contemporaneous documentary evidence to support the oral account. So if you have inconsistency between your oral evidence and what you've written in the past, it will smell of inconsistency, and that will be picked up on very quickly. And that's what, there's no surprise the lawyers are trained to do. So be clear, be concise, and logical. So that's a whistle-stop tour of the frameworks of the medical legal issues that we work in. I end it with some quotes. Marcus Aurelius' quote, "I learned to read carefully and not to be satisfied with the rough understanding of the whole, and not to agree too quickly with those who have a lot to say about something." That may also apply to my talk, but what I say is that it's worth a read. It's worth looking into these things, and I apologise in some ways of putting myself in the salubrious bracket as Marcus Aurelius, but this is my own quote, which I like to say, is that display competence before confidence, and I don't think you go far wrong. Many thanks.